in the home stretch. I don't mind you napping, it's okay. So my name is Rheoneil Lascano. I'm a nurse practitioner. I work here in the cath lab, and my topic today is the importance of PAD detection on cardiac nursing practice. Forgot to thank Beth and Tom for inviting me to give this talk. The button is huge. I didn't see it. Okay, so when I was given this topic, the importance of PAD detection in cardiac nursing practice, I immediately thought to myself, oh my gosh, what the hell did I get into here? Because I'm just so used to talking about vascular devices and vascular anatomy and all that stuff, but this is an entirely new thing for me. So what did I do to get some information for my talk today is, what regular, like everybody, everyday people do, they go to Google. So I went ahead and Googled PAD, cardiac nursing practice and all so forth. And what's surprising to me, what I came out with is that healthcare professionals like us, nurses, NPs, PAs, are not fully aware how peripheral arterial disease impacts so many of our patients, especially in the cardiovascular space. And that the nurses, PAs, and NPs are in a unique position to monitor and detect lower extremity PAD in both inpatient and outpatient setting. So my hope is here today is to make you guys aware of the impact of peripheral arterial disease have on our patients that we take care of on a daily basis. So what is peripheral arterial disease? PAD is an obstruction of blood flow to the non-heart or non-brain arteries. So when we talk about PAD, we could talk about carotid arteries, we could talk about subclavian arteries, arteries of the limb, upper limb. But for the purpose of my talk, my presentation today, I'm going to be talking about arteries of the lower extremities. So you can see on the slide here, PAD affects approximately 8 to 12 million Americans, which is great for our stage here today. But more than 230 million people worldwide are affected with PAD. So is PAD a common disorder? Well, with the partners, you can see here in the slide, according to a partner study, it is. PAD occurs to about 1/3 of patients, specifically those over the age of 70, and those patients age 50 and above who smoke and have diabetes. It's a progressive disease in 25% of patients with intermittent claudication, which progresses to a limb-threatening ischemia. And the outcomes results in impaired quality of life, limb loss, and premature mortality. So what are the risk factors? The normal culprits, right? Cigarette smoking, diabetes, hypertension, hyperlipidemia, similar to those with risk factors for CAD. So who are at risk for lower extremity PAD? Well, you can see on the slide, I'm going to just read off the slide. Age less than 50 years with diabetes and one risk factor, either smoking, high cholesterol diabetes. Age 50 to 69 years and a history of smoking or diabetes. Age 70 years and older. Patients who have leg symptoms, either suggestive claudication or ischemic rest pain. Abnormal lower extremity pulse examination, and patients with known CAD or renal artery disease. So how do we screen for these patients that come to our clinic? So history and physical is very important. Assess risk factors, skin integrity, excess capacity, so forth. Comprehensive vascular examinations, checking pulses, radial pulses, and so forth. And the crux of it is really the non-invasive diagnostic testing. So we're going to talk about ABI, segmental pressures, and arterial ultrasounds. CTAs and MRAs are also good non-invasive diagnostic testing to ascertain what PAD is all about, but that's more of a hospital setting, so I won't touch on that today. So what are the guidelines? So patients who are at risk, which we discussed earlier in that previous slide, gets ABI index, ABI measurement, which is a ACC/HA guideline. So what is an ABI? So an ABI is the ratio of a higher brachial systolic pressure and a higher ankle systolic pressure for each leg. And you can see in the illustration there how the test is performed. You plug the numbers into this equation, and you get a value. So a value of 1.0 to 1.29 is considered normal. 0.9 to 0.99 is considered borderline for PAD, and 0.41 and to 0.90 is considered mild to moderate disease. Less than or equal to less than 0.40 is considered severe disease. So you can see the ankle brachial index is about 95% sensitive and 99% specific for PAD. It establishes the PAD diagnosis and identifies the population at high risk, which was listed here, which we discussed earlier. So in addition to ABIs, we could also perform segmental pressures, which is a test that measures blood flow within the arteries. And as you can see here with the illustration, the patient is wrapped with pneumatic blood pressure cuffs in different areas of the lower extremity. And those cuffs ascertain pressures between the levels of the cuffs and between the levels of the extremity. So as you can see, greater than 30 millimeters of mercury of drop between the levels may indicate PAD. And anything greater than 20 millimeter mercury of pressure between the limbs may indicate one limb is more severe than the other. And if you could look at an illustration on the right side, the upper thigh, the lower thigh, and everything, the waveforms are normal there with the dichotic notch. But on the left side, the upper thigh, the lower extremity, you can see that the waveforms get diminished, and therefore kind of indicating that this patient who had this test may have some PAD going on in the left leg. The other non-invasive testing that we're talking about here is this arterial duplex. It's a non-invasive method to evaluate the blood vessels of the lower extremities. It can obtain both anatomical and hemodynamic information, and the anatomical details such as vessel wall, intramural obstruction lesions, and perivascular comprehensive structure can be obtained by arterial duplex. So key takeaways for my talk really is early detection of PAD. It is clear that peripheral atherosclerosis remains an important marker of mortality from other cardiovascular causes such as MI and stroke. Early detection is important. Patient's history, physical examination, and non-invasive testing. We have to modify the risk factors as shown here. And educational awareness helps reduce the size of this underdiagnosed population and to improve prognosis. The direct impact of lower extremity disease on quality of life is often masked by typical slow, steady progression of the disease. Many patients who have mild symptoms may alter their activities to accommodate the changes of the peripheral arterial flow. And increased awareness of peripheral arterial disease through screening, early treatment, and education can help to improve the quality of life and significantly reduce the morbidity and mortality of these patients. Thank you for your time. Yes. Terry, give me a hard time. Mm-hmm. Yes. I mean, AI is an upcoming kind of innovation that will definitely help us in our practice. There's some barriers, like Dr. Kinney presented this morning about, calcium and how could it detect calcium and different types of plaques. So that might be a barrier to getting AI into peripheral arterial disease, but, it's certainly a good, innovation that we could put into peripheral arterial disease management, for sure. So you did see something coming up in your I haven't really seen much. And I haven't really researched it much, but and I haven't really heard much about it. But it would be a nice thing to incorporate when it does come up. And, I guess, what happens is PAD is like the stepson for CAD, You have a lot of CAD already with their studies and so forth, and you can see that with Dr. Sharma with all the studies for CAD. But, PAD is really an infant type kind of upcoming disease process that we have to really kind of worry about and think about because it's not as elaborate as CAD is, So it may come. I guess it may come when CAD establishes that AI. It may incorporate down into the PAD system, yeah.
That was a great
Thanks, Terry. Thanks for the question.